Hello, I'm Rashad Khazi Syed. I'm one of the electrophysiologists from Wisconsin, and I would like to take an opportunity to thank Dr. Alpert and the whole of the hosting team for giving me an opportunity to talk at this esteemed event. And I have been delegated with the responsibility to talk about the barriers that are there to the lifestyle changes for prevention of atrial fibrillation. I don't have any disclosures. Barriers, there are no constraints on the human mind, no walls around the human spirit, no barriers to our progress except those we ourselves erect. And that was by Ronald Reagan. I'm not having any political debate here at this time. And risk factors for atrial fibrillation. They are broadly classified into two groups. One, non-modifiable, and the other is the modifiable. The non-modifiable risk factors where we have absolutely no control, at least as of yet, are the gender, the ethnicity, the race, and the genetics. And of course, maybe in the future, we may have some control over the genetics, but at this point, we don't have control on that at all. And today we'll be concentrating more on the modifiable risk factors that include physical inactivity, smoking, obesity, obstructive sleep apnea, hypertension, and diabetes. As we all know that all these non-modifiable and modifiable risk factors, they interplay and are responsible in some way or other, resulting in atrial fibrillation. And if you look into it, all these modifiable and non-modifiable risk factors, they result in fibrosis, thereby slowing the conduction and electrical uncoupling in the atrial musculature. And they are responsible for increased inflammatory mediators, especially the interleukin-1, interleukin-6, CRP, and tumor necrosis alpha factor, and cellular and molecular changes, which result in shortening of the ERPs and intracellular calcium overload. That results in both structural remodeling and electrical remodeling of the atrium, resulting in atrial fibrillation. The first risk factor that I'll be addressing is the physical inactivity and sedentary lifestyle. As we all know that the sedentary lifestyle is a risk factor for atrial fibrillation, and there is a paradoxical extreme exercise is also associated with increased risk of atrial fibrillation. For every 1 MET increase in cardiorespiratory fitness is associated with a dose-dependent decrease in atrial fibrillation risk by about 7%. And in women, there is an inverse linear relationship that results in increased physical activity association with progressive and decreasing AF risk. If you look on the right side, on the left side of the screen, in men who are sedentary, there is a higher risk for atrial fibrillation. But as they start exercising, the risk for atrial fibrillation goes down. And as they increase their exercise abilities, the risk of atrial fibrillation goes up again. Whereas in women, there is an inverse linear relationship where as they increase their intensity of exercise, the risk of atrial fibrillation keeps going. And one of the reasons for the athletes are endurance athletes having atrial fibrillation is the increased vagal tone that shortens and increases the dispersion of atrial ERP and cardiac remodeling that results in left atrial enlargement and fibrosis that again in turn puts them at a higher risk for atrial fibrillation. As far as the barriers for fitness are concerned, lack of time is the most common, probably an excuse, but still is a barrier. Friends and families don't share our interest or your interest in physical activity or the patient's interest in physical activity. So when they get together, they're not running, they're not exercising, but they're sitting and enjoying food or having drinks and just watching TV. And of course, lack of motivation and energy. There are a lot of patients who are doing 3 jobs, and at the end of the day, they don't have either motivation or energy to engage in any kind of physical activity. And even if somebody is motivated and they may not have necessarily resources or equipment for them to engage in any kind of physical activity. And some of the patients may have family caregiving obligations. And as I mentioned earlier, there are people who are working 3 jobs. And all they can do is work and work and work, and they don't have time to engage in any kind of physical activity. And of course, the fear of injury, or people are traveling all the time for work. If they're not traveling, they're working, and if they're not working, they're traveling. And that could be a difficult lifestyle to incorporate physical activity. And of course, in certain areas, the weather conditions may not allow physical activity during certain months of the year. And the next barrier I'm talking about is the smoking cessation, or smoking. Both the Birmingham study as well as the Rotterdam study have clearly shown an association between smoking and atrial fibrillation. Eric's study has shown that the incidence of atrial fibrillation is 1.5 times higher in ever smokers and 2.2-fold higher in patients who are current smokers when compared to non-smokers. Even the secondhand smoking, especially when the fetus in utero exposure or during the early developmental ages or early childhood exposure, can increase the risk of atrial fibrillation by almost 40%. In North America, 40% of the smokers are from the LGBTQ communities, Native Americans, and Native Alaskans. And 2/3 of the world's smoking population are smokers are in the developing countries. If you look into the barriers, they are classified into 5 themes when it comes to smoking. The first theme is the lifestyle and social factors, where there is inability of a patient to resist the temptation, and they have friends who are smokers, and there's lack of willpower from the patient to, or they lack self-control, or they even lack motivation to quit smoking. Those are responsible for their continuing or failure to give up smoking. And the theme 2 is the nicotine addiction. The nicotine addiction could be either physiological, because they enjoy when they smoke, or it could be physical, where they have withdrawal symptoms associated with trying to quit smoking. And the third theme is the social and cultural, where when the patients meet with their friends or family, smoking is a normal phenomena there. They're all sitting together and smoking, and that's a cultural, and it could be social also, especially if you look into lower social economic status groups. They usually, when they get together, they sit together and smoke together. So those cultural and social issues can also become barriers to smoking cessation. And then the fourth theme is the misconceptions. Misconceptions among the patients that quitting smoking can be injurious to health. And some of these patients have rationalized their smoking habits so well, and to an extent that they feel that they'll get sick if they quit smoking. And there's misrepresentation of cessation of smoking as associated with worsening of the health issues. And they feel that it is therapeutic for them to help with stress relief. All these misconceptions act as a barrier to quitting cigarettes. And of course, the fifth theme here is the failed assisted smoking, where the patients have tried various medications and also tried nicotine gums, nicotine patches, and they have failed to quit smoking. And now they think that these things don't work. That becomes an issue in these patients, and they fail to, again, re-engage in any effort to quit smoking. And if you look into these schemes, of these 5 schemes here, the first 2 schemes, the scheme 1 or the theme 1 and the theme 2, these can be addressed with short-term strategies that can last up to 3 months. And whereas the theme 3, 4, and 5, these can be addressed with long-term strategies that can be 12 months or longer. And some of them may in fact need some kind of intervention from the government with policy changes. And when you look at one of the studies that showed some bivariate analysis, where they looked at the male and females and daily smokers and sometimes Sunday smokers versus people who have tried to quit smoking in the last 6 months or who intend to quit smoking in the next 6 months. And all of these patients, if you look into it, the most common reason or a barrier they have mentioned is the loss of weight to handle stress, whether you across the demographics, like if you look at the age or the ethnicity or race or education level, you look at any of these demographic differences, and all of them have consistently referred to as loss of weight to handle stress as one of the barriers. And the other one is the craving or the withdrawal from smoking as a big barrier for them. And of course, there are vulnerable groups like LGBTQ communities or people with mental illness or substance abuse. They use smoking as a stress management strategy. And smoking is very prevalent among these communities, and it is very acceptable activity, so they don't feel a need to quit smoking. And of course, being a vulnerable group, they do not have access to support system like others do. If you look into it, mental health, people with mental health conditions and substance abuse mark up to 22% of the population, but account to only 38% of all cigarette smokers. The next risk factor I'll be dealing with is the obesity, where if you look at the meta-analysis, the obesity increases a patient's risk for atrial fibrillation by about almost 50%. And for every 1 unit increase in BMI, the associated risk for atrial fibrillation goes up to almost by 5%. And if you look on the right side, the map on the top shows the prevalence or the incidence of atrial fibrillation hospitalizations in US. And if you look at it, the Midwest and the East Coast have the highest. And if you look at it, at the bottom is the obesity prevalence. They kind of match. So there is a clear, as we all know, a clear relationship between obesity and increased risk for atrial fibrillation. As far as the barriers are concerned, with any risk factor, the barriers can be classified as a patient level or interpersonal, at a society or a community level, or can be a physician or physician and patient relationships. If you look into it at individual level, it's because lack of access to healthy food options or lack of access to weight loss referrals, and there is limited education attainment or literacy levels can also interfere with weight loss because of their beliefs or their lack of understanding thereof about the obesity and its related adverse effects. And of course, there is lack of interest and motivation to lose weight at individual level also, which acts as a barrier. And when you look at the interpersonal, there are in certain communities, there is a positive association with larger body sizes being considered as a healthy sign, whereas people with smaller bodies are considered to be sickly and not healthy. And that can also play a big role in certain communities and ethnic groups, especially. A lack of awareness of overweight and obesity because of the high prevalence of these conditions within the patient's communities is also a big barrier. If grandfather is obese, and if the father is obese, if the brother is obese, if the sister is obese, and the patient is going to perceive obesity as something that is not abnormal, and that can be a big barrier. And of course, if you look into the communities, there are limited availability of healthy food options in certain communities, especially if you go into the areas where the low socioeconomic status is much more prevalent. In those areas, they may not have access to a good and healthy food options. And it could be related to culture also. Like here in America, if you go into the southern states, everything they eat is deep fried. That's not healthy, but that is their lifestyle. And if you look into the obesity barriers, they can be broadly classified into first order barriers and second order barriers. And the first order barriers has resource support, where there's lack of resources, especially for the physicians in solo practice or in the rural areas. They don't have access to better referral basis, so they can send these patients to the organizations or the healthcare centers or that specialize in treating obesity. Or that could be due to logistics, because there's lack of The patients may be living so far from any place that is able to provide these services, and it becomes a logistical nightmare for those patients to go there often to address these issues. Or lack of knowledge, the lack of knowledge, especially among the physicians, about what they can do to help these patients, where they can refer, or their own perception of bariatric surgery, which may be skewed, and that can prevent them from referring these patients to seek higher care for these issues. And the second order barriers are the root cause, where there's lack of food, choices, and patients make very poor food choices, and they have very poor dietary habits. These things, or they can have food addictions. That can be a big barrier in these patients. And the patients sometimes lack motivation. And of course, there's perception of bariatric surgery, where the physicians feel that it is too complex and too complicated, and it's a high-risk surgery, and they don't have better understanding of the short-term and long-term consequences of bariatric surgery. So they feel not too comfortable discussing these options with the patients. And if you look into it, the lack of knowledge is a leading barrier. In one of the studies, they found out, especially among the adult British population. And when you look at most of the adults in the EU, the lack of time and self-control were major barriers. And the most important thing when it comes to addressing these barriers is that when you address or start addressing the weight loss, usually in the short term, there is a lot of improvement in short term due to dietary changes, and because we're more efficient in reducing these barriers. But once they go from this acute phase into maintenance phase, there are not many strategies to keep maintaining certain amount of barrier reduction that can interfere with long-term outcomes. And the next one is the sleep apnea. As we know that sleep apnea increases the risk of atrial fibrillation by 4 to 6 folds. And people who have atrial fibrillation, obstructive sleep apnea, are at increased risk of post-op atrial fibrillation, and they have a higher recurrence of atrial fibrillation after cardioversion and ablations. And again, the barriers, patient-related, therapy-related, or health professional-related. CPAP, as we all know, is a very well-established therapy for obstructive sleep apnea, but 18% of the patients refuse to initiate this therapy right at the time of the diagnosis. Even if they start, about 30% of the patients abandon the use of CPAP by the year 5. And as high as 83% of patients do not use CPAP as advised. And that is because the patients don't have a proper understanding and of the importance of the CPAP in treatment of obstructive sleep apnea, or they fail to understand the instructions, or they are concomitantly using other medications like sedatives, or they may be engaging in alcohol that can interfere with the use of CPAP. And they may start feeling ill, especially among the smokers. They have recurrent URTIs that prevent them from using the CPAP consistently. And physical limitations. If somebody has coordination problems or vision problems, it becomes too cumbersome for them to put on this mask and use the CPAP. And of course, therapy related, they may feel that the device functioning and the use is too complex for them, and they can have device related issues like nasal irritation, nasal congestion. They can have dry mouth, and they feel uncomfortable, and they can feel claustrophobic from using this mask, and they can have eye irritation. The air leaks can prevent them from having good sleep. And of course, there is a health professional related that where there is a poor relationship between the patient and the physician. And if at any point, if the physician shows any kind of doubt in the efficacy, it's done. The patient is never going to follow through on the treatment with a CPAP. The next one is the hypertension. As we know that Framingham studies have clearly shown increased risk of atrial fibrillation in hypertensives. And elevated hypertension at subsequent follow-ups is associated with increased risk of atrial fibrillation. As we know, hypertension causes LVH and systolic dysfunction and diastolic dysfunction that results in left atrial enlargement and increased pressures that result in hypertrophy and fibrosis, thereby increasing the atrial structural and electrical remodeling and atrial fibrillation. And if you look into the barriers, again, they're pretty much similar to the other barriers, where there could be behavior at the level of the provider level, where is the physician well versed with the clinical guidelines that are available out there, and is making sure that his patients are adherent to these guidelines. And when you look at the patients, are the patients aware about what the hypertension is all about, or what their treatment is all about, and how do they address their lifestyle better? And then if you move on, these barriers to behavior changes can be a big problem, because lack of knowledge or skills, or patients may not be motivated, or sometimes they have a difficult time breaking their habit, or there could be social influences that may interfere from them addressing their barriers. And if nothing, then we have this issue with health systems. Is the proper healthcare available for these patients? If it is available, is it affordable? And if it is affordable, is it acceptable to the patient? All these things do play an important role in control of adequate barrier control in hypertension. And if you look into it, it's the weight. Excess weight is a big problem for adherence to the therapy, and the perceived behavior that it does not help, or the side effects from the medications are the big barriers to treatment for the atrial fibrillation. And the last one is the diabetes. And as we all know, that Birmingham heart study has clearly shown that women with diabetes are at increased risk of almost about 40% compared, to 60% of risk of developing atrial fibrillation compared to men, who are at about 40%. And for every year of diabetes, the risk of atrial fibrillation goes up by about 3%. And again, the barriers are divided in the patient-related, the provider-related, and patient-provider interaction, and healthcare-related. And if you look at the therapies, oral hypoglycemics have higher adherence compared to the insulin, and a positive attitude is associated with better outcomes. Right at the first discussion, when a patient needs insulin, about 33% of the patients are usually not willing to take insulin as treatment. And if you look at the Hispanic population, they consider insulin as harmful. And among the Hispanics, emotional and cultural barriers are much more harder to address than the economic barriers. In Chinese, the freedom to enjoy food is a big barrier. And the other competing comorbidities can also interfere with chronic health condition care. And of course, the financial resources is a big problem. And if you look into the patient and physician provider relationship, it's a better communication predicts better outcomes. If there is no better communication between the physician and the patient, then obviously the outcomes are not going to be what we want them to be. And the biggest problem these days we face is it's so hard to accomplish this comprehensive counseling in primary care setting, because everyone wants to see certain amount of patients in a day. And if they're going to see so many patients in a day, to accommodate those patients, they cannot spend enough time to address these patients in detail, and to address their concerns, to answer their questions. They don't have time. And that, again, becomes a barrier. And if you look into it, about 40% of the patients with diabetes have psychological symptoms, but only 10% of them are treated for these. I think that's pretty much it about the barriers that we face in treating the lifestyle, to change the lifestyle modifications in patients to decrease their risk for atrial fibrillations. Any questions?
Thank you, doctor, for your nice presentation. I would like to ask you a question. My question is there data to suggest an upstream non-procedural interventions result impact on other outcomes such as cardiovascular, hospitalization, cerebrovascular events, and mortality? Thank you.
It's a good question. And well, there is data that shows that there is a benefit with lifestyle modification and risk factor modification in patients with atrial fibrillation, where we have improved the health status as well as cardiopulmonary status in these patients. But does that translate into cardiovascular hospitalization and cerebrovascular events and decrease in mortality? Well, we still need a lot of data here, and we need more evidence to clearly show that there is a clear benefit here in these situations. So how do we do that? We need more prospective randomized controlled trials looking at these questions and answering these questions. And we need to define the treatment targets for these risk factors so that we can achieve them better. And of course, we can use the current available mobile technologies to help in these in achieving these goals. And of course, the last but not the least, engage and educate. So we have to come up with better ways to engage our patients and physicians, and also to educate both the physicians and the patients. Does that answer my question?
Yeah, thank you, Doctor.
Thank you for nice presentation, Doctor.
Thank you.
I have one question. My question is, obesity seems to be a common denominator over which other risk factors rest. Is there evidence for best practice for weight reduction? And if so, who is doing it and can make that happen in my practice?
Well, there is a lot of data coming out, especially from Dr. Presh Sanders' Institute in Australia. So University of Adelaide, they are doing excellent groundbreaking work in this regard. And they're coming up with a lot of data, especially the weight loss and various other risk factor management in decreasing the AF incidence and recurrence and treatment. And they certainly are, there is data that supports that weight loss certainly helps reducing not only just weight loss related benefit on atrial fibrillation, but the other risk factors that are associated with obesity can also be addressed. And it is quite possible, but it is going to be labor intensive, and you can do it. And I'm pretty sure everyone or most of the physicians are trying to do it in some form, in some way. But to have a good outcome like Dr. Sanders' group, you need to have a multi-pronged strategy where you're involving multiple specialties to address, and they convene and they help the patient from every possible angle, rather than you just sitting there and talking to the patient, giving them a lecture. It's not going to help, but we have to walk the talk. That means we have to provide them with the services that they need. So it is possible, and it requires a lot of effort from the physician and also from the institutions to be able to invest in these long-term, because these are not something that you can achieve. Like you may have some short-term benefits, but for long-term benefits, there has to be a sustained investment, both from the physicians, from the patient, and of course, the institutions that we work for or work with.
We thank you very much.